Welcome to a lecture this evening by Dr. Scott Kline, the Good Samaritan and Healthcare Justice. My name is John Martins and I direct the Center for Christian Engagement at St. Mark's College at UBC. I'd like to begin by acknowledging that the land on which we gather is a traditional, ancestral, and unceded territory of the Musqueam people. We're so thankful for their welcome to us so that we can live, learn, and pray on their land. It's our goal that the Center for Christian Engagement become a source of healing and reconciliation by examining the past truthfully, accompanying those suffering today compassionately, and by acting humbly and wisely as we move forward together. This includes, importantly, the need to hear directly Indigenous voices, especially those of those local to Musqueam people and others, so that we can act wisely and with empathy. Center for Christian Engagement at St. Mark's College emphasizes the importance of listening, reflecting, learning, discussing, and praying as we explore the Christian and Catholic intellectual tradition and seek to learn from others. I want to also thank especially the Cullen family for their generous support of this lecture series. Barb, who's here with us, and Mark, who's at home comfortably watching from there. Thank you so much for your support and your generosity. I also want to thank our donors to the center, Peter Bull, Angus Reid, and Andy Zox, for their opportunities to let this work take place. We're thankful for their commitment to the life of the academic world and of the church, the work of the church in the world. Many of you are joining us virtually, and we're thankful that you're with us, and we're also thankful for those who are here with us in person. At the end of the lecture, for those who are at home, you'll be able to ask questions in the chat function, and we'll be monitoring your questions on Zoom, and we'll try to ask as many as possible. Before we begin, I want to talk a little bit about our speaker and about his topic. Scott Kline, who's speaking on the Good Samaritan and Healthcare Justice, is offering a topic that's so relevant for the church and the world, especially for a church that Pope Francis has likened to a field hospital. But even if that's meant particularly in a spiritual sense, the physical care of neighbor has also been a major part of Catholic social teaching and service to the world. The lecture here emerges from Jesus' own teaching on what it means to be a neighbor, the parable of the Good Samaritan. Just want to give one short anecdote as I was thinking about Scott's lecture. In Rodney Stark's book, The Rise of Christianity, I remembered this scene, and I went back and found it to make sure that I hadn't made it up. He posits that Christians in late antiquity acted with greater benevolence during ancient pandemics and epidemics. This is page 86 of the book. The famous classical physician Galen, one of the great physicians of antiquity, lived through the first epidemic during the reign of Marcus Aurelius. Stark asks, what did he do? He got out of Rome quickly, retiring to a country estate in Asia Minor until the danger receded. But the Christians stayed to care for the sick because, quote, God demonstrates his love through sacrifice. Humans must demonstrate their love through sacrifice on behalf of one another. Moreover, such responsibilities were to be extended beyond the bounds of family and tribe. These were revolutionary ideas. In this lecture, Dr. Scott Kline appeals to the parable of the Good Samaritan to make the case for an approach to healthcare ethics that's rooted in Catholic social teaching. As he writes, the parable of the Good Samaritan has long been a model for Christians seeking to care for the sick and heal the wounded. So moving is the story of the Samaritan coming to the aid of an injured victim along the road that many hospitals, clinics, health networks, and retreat centers around the world have taken on the Samaritan as their defining symbol. But the parable of the Good Samaritan is not specifically about responding to the wounded, the diseased, or the sick. It's part of an answer Jesus gives to the legal scholar who's asking about the integral connection between pursuing eternal life and caring for one's neighbor. Dr. Scott Kline is the inaugural visiting scholar in ethics at Providence Healthcare and St. Mark's College at UBC. Kline holds a PhD in Christian social ethics. He has extensive academic teaching experience, is an established theologian and researcher. He's also served as the interim president and vice chancellor at St. Jerome's University, University of Waterloo, and is currently chair of the Department of Religious Studies at St. Jerome's University. Scott's general research in ethics, politics, and public policy are extensive. His current project focuses on rapid community response to sudden out-of-hospital cardiac arrest. He's a member of the Heart and Stroke Foundation's Resuscitation Advisory Committee and part of the CanSave Research Cluster at UBC and St. Paul's Hospital, which focuses on increasing survival rates from cardiac arrest. He's the author of numerous articles and the book, The Ethical Being, A Guide to Contemporary Issues from 2013. He's currently writing a book on Catholic social teaching, the Good Samaritan, and healthcare justice. So we have him right in the heart of his wheelhouse. Scott, welcome here.
Thanks, John. As you were saying those last words, I was about ready to jump up and say that my goal is to have the book ready for Christmas, so be prepared to buy it. That's all I have to say. I want to begin tonight by thanking everyone at St. Mark's College, the St. Paul's Foundation, Archbishop Miller, and Providence Healthcare for supporting me in the visiting scholar in ethics position this year. It has been, in my life, a momentous year, coming to Vancouver as much as I could. COVID certainly got in the way of some of the plans that we had along the way. Over the course of the last, 7 or 8 months or so, I can't tell you how many times I've gone back and forth between Vancouver and Toronto. I live in Stratford, Ontario, so it's been a lot of commuting. So that wasn't the original plan, but we've made the best of it. So I'm now a part of the story at St. Mark's, and you certainly are part of my story. So it really has been an honor to be with you these past few months. So on to the topic at hand, the Good Samaritan and healthcare justice. I have no idea what's awaiting me or what will happen when this all ends. For the moment, I know this: there are sick people and they need curing. While these could easily be the words of an emergency room doctor attending to patients suffering from the deadly effects of the coronavirus, they actually belong to Bernard Rieu, a fictional character in Albert Camus' 1947 novel, The Plague, a story about what happens in the North African city of Oran as people there come to terms with a mysterious epidemic. I have taught The Plague for many years in an ethics class for university students preparing to embark on a 4-month international service learning term. I ask my students to consider why Dr. Rieu does what he does. He sees so much suffering, so much death. He knows that he will relieve the suffering of a small number of people, and that he will save even fewer lives. He is also fully aware that he is risking his own life in doing all of this. At the height of the plague, Dr. Rieu encounters a Catholic priest who questions the doctor about his lack of belief in God and whether he is concerned about his soul. Dr. Rieu tells the priest over the course of several conversations that while he has contemplated the existence of God, the possibility of an afterlife, and even whether his current life has purpose, it is not fear over what's waiting that motivates him. He just knows that people are sick and they need help. And helping the sick is the right thing for a doctor to do. Tragically, the COVID-19 virus has generated countless real pandemic stories. Since late 2019, hundreds of millions of people around the world have been infected by the deadly virus. Estimates show that more than 6 million people have died from COVID-related diseases. We've experienced so much suffering, so much death. We've lost family members, friends, colleagues, and neighbors. We grieve their passing even as we celebrate their lives. Throughout this pandemic, we've supported one another with hope-filled stories. We've told stories about how important healthcare workers are to our communities. We call them heroes as they head off to hospitals, long-term care facilities, and emergency health clinics overwhelmed with the sick. Many of our healthcare workers have suffered from physical exhaustion and mental fatigue. The virus has stretched our healthcare system to a breaking point. And yet, in spite of their already heavy loads, it has been the sheer commitment of nurses, doctors, healthcare practitioners, and personal support personal support workers, as well as operational staff such as cleaners, food service personnel, and hospital attendants that has kept the system from utterly collapsing. There are sick people, and they need our help. Moreover, we've come to recognize in stories too numerous to name that we do in fact rely on essential workers to keep our essential services running. These are not only healthcare workers, but also grocery store clerks, meat packers, agricultural workers, truck drivers, school teachers, and daycare workers, to name just a few. Through many of these same stories, we have also heard stories of injustice. For example, we've learned that personal support workers may be working full-time to care for our most vulnerable community members, those who are sick, but they don't earn enough to live. We've heard stories about shockingly unsafe conditions in our long-term care facilities, distribution warehouses, and even some of our schools. Many living and working in these environments have been putting their health at risk for years. COVID has only highlighted the unsafe, unjust conditions. The pandemic has also highlighted once again the socioeconomic disparities in healthcare access and outcomes. For instance, in the United States, Black and African American communities were disproportionately affected by COVID-19 in the first 18 months of the pandemic, with higher case rates, more deaths, and more severe economic effects than other racial and ethnic communities. Why was this happening? Surveys tell us that it was due to the lack of access and vaccine hesitancy, fueled by stories about morally reprehensible studies carried out on Black men in the 1930s. Behind all of this is the dehumanizing structural evil of racism. The historical injustices suffered by Black people at the hands of political, educational, and medical institutions continue to have harmful effects on the health of Black people today. I've been teaching courses in ethics for almost 3 decades. I guess it means I'm a bit old. One of the lessons I've learned during this time is that teaching ethics is best done by introducing students to stories that speak to them, challenge them, and invite them to contemplate their meaning. My hunch is that this approach to teaching ethics works well because our ethical reasoning is naturally developed through the stories we encounter around the kitchen table, in our schools, in our clubs, over coffees or beers, with friends in our youth groups, and so on. We share stories about our families, friends, and communities. Stories are how we remember and memorialize. They have the capacity to shape, reshape, and explain our experiences. They help us make sense of the world and our place in it. They can inspire us, teach us, challenge us, and call us to action. Stories can upset the status quo. They can communicate something core about what we as human persons value or ought to value in life. Our stories connect us to a past and provide us with a direction for the future. They help us answer fundamental, big questions in ethics, such as how shall we live and who do we hope to become? Figuring out what stories mean can be tricky. Stories must be interpreted and reinterpreted if they are to mean something to us. What a story means to us today may mean something different to us later as our horizons expand and as we grow in knowledge and in wisdom. We may come to recognize that stories, even the simplest of stories, can have several layers of meaning. Hannah Arendt, one of the most provocative and insightful philosophers of the 20th century, observes, and I quote, "Storytelling reveals meaning without committing the error of defining it," end quote. In other words, the storyteller must not succumb to the temptation of simply telling us what the story means or what the storyteller thinks it means. Rather, it is up to us, the interpreters, to reconcile the reality of the way things are now with the possibilities that confront us in the stories we read and hear. One of the stories we Christians like to tell when we consider the gospel imperative to heal the sick, which we find in Matthew 10, verse 8, is the parable of the Good Samaritan, which we find in the Gospel of Luke, chapter 10, verses 25 through 37. In fact, the Catholic Healthcare Alliance of Canada uses the parable of the Good Samaritan as a way to frame the most recent edition of the Health Ethics Guide, which was published in 2012. The Health Ethics Guide is important because it outlines the moral obligations for the sponsors, owners, boards, members of ethics committees, and personnel of Catholic health and social services organizations. The Samaritan story is one that Jesus tells a Jewish legal scholar in response to the question, "Teacher, what must I do to inherit eternal life?" Jesus prompts the scholar to give the correct answer in accordance with Jewish law. Love your neighbor as yourself. But the legal scholar isn't fully satisfied with the answer, so he asks Jesus another question, "And who is my neighbor?" Jesus then tells the story of a man left along the road, half dead, the victim of an assault. A priest, no doubt heading home to his home in Jericho from the temple in Jerusalem, doesn't just pass by the injured man without helping him, but he actually crosses the other side of the road to avoid him. And then a Levite, whose vocation is to help priests carry out religious rituals in the Jewish temple, he walks by, and he too decides to cross the road to avoid the half-dead man. Finally, a Samaritan, who belongs to a group of Jews considered to be heretics, he sees the injured man, and is moved by compassion and comes to the aid of the victim. Not only does this despised Samaritan provide immediate care, but he also ensures that the man is cared for in the longer term. The Samaritan leaves the injured man with an innkeeper and gives the innkeeper money to be used to nurse the man back to health. The story ends with Jesus asking the question of the legal scholar, "Which of these three do you think was a neighbor to the man who fell into the hands of the robbers?" The scholar says, "The one who showed him mercy." Jesus replies, "Go and do likewise." So let me make a few general observations about this parable. First, the parable style is consistent with other parables recorded in the Gospels of Matthew, Mark, and Luke, the so-called synoptic Gospels. The Gospel of John actually doesn't contain any parables. While John's parables contain echoes of traditional rabbinical parables, they were different. Joachim Jeremias, the author of the classic book, The Parables of Jesus, which was first published in 1954, observes that in comparison to other parables from the same period and cultural context, Jesus' parables have a unique clarity and simplicity. In them, hearers find themselves in a familiar scene, Jeremias writes, where everything is so simple and clear that a child can understand, so plain that those who hear can say, "Yes, that's how it is." Second, in telling the Samaritan story, Jesus' followers did not need to be told what to think about the priest, the Levite, or the Samaritan. They already had well-formed opinions about these characters. They had shared stories about them. They knew how each character was supposed to act. They knew the script. So as the story of these characters went off script, with the hated Samaritan coming to the aid of a critically injured victim, it would have prompted further conversation, more debate, and a new ethical problem to be figured out, which was precisely the objective of the parable, to get a conversation started, to talk about what was happening in the story. And third, like any good storyteller, Jesus did not tell his followers what the story actually meant. He left it up to his followers to figure out. But what did the story actually mean then? And what does it mean now? These are complex questions that require complex answers. But let me try to simplify things without offending too many New Testament scholars. And I'm actually thinking about you, John, so bear with me here for a little bit as I completely abuse your field. To begin, there is a consensus among current parable scholars that all of the parables had one overriding message: the kingdom of God, the imminent kingdom of God. In the decades following Jesus' death, it had become popular to interpret the parables as allegories that concealed the mystery of the kingdom of God from outsiders. Surely Jesus had to be talking about something else, something far more profound when he tells stories about crooks, dysfunctional families, ungrateful children, sacrilegious separatists, despised tax collectors, incompetent farmers, persistent women, unfruitful fig trees, and a whole slew of this worldly conundrums that would have undoubtedly made followers' ears perk up with interest. Indeed, by the 4th century, St. Augustine had developed an allegorical interpretation of the parable that identified Jesus as the Samaritan, Adam as the victim, the innkeeper as St. Paul, and the thieves as the devil and his fallen angels. By the 20th century, the long tradition of allegorical interpretations had given way to historical critical approaches. Today, New Testament scholars use historical, sociological, and literary analyses to illuminate the meaning of Scripture, to help us better understand the meaning of the parable in its original context. While historical critical approaches to parables remain popular among scholars of early Christian literature, a decidedly ahistorical approach continues to hold sway among many pastors, homilists, and even moral theologians giving public talks. I'm looking at myself. The Catholic New Testament scholar, Father Gerhard Lofink, observes that it is quite common these days to regard Jesus' parables as autonomous aesthetic constructions that communicate universal wisdom, which can be applied to a wide range of contemporary situations that call for action amid moral uncertainty. This is Lofink's fancy way of saying that we should not, indeed must not, treat Jesus' parables as saccharine stories designed to elicit sentimental meaning solely for the individual consumer. They're not the stuff you should find in the self-help section of the bookstore, nor are they isolated nuggets of ethical wisdom to be used indiscriminately in the odd Hallmark card, sermon, homily, or again, public lecture. No. For Lofink, if we regard, and I'm quoting here, if we regard Jesus' parables as autonomous aesthetic constructions that stand by themselves, we will too easily miss what they have to say. Then we will see them only as general ethical admonitions, acute precepts of wisdom, or the uncovering of realities of human existence. But Jesus' parables were decidedly more than that, Lofink writes. They spoke of the urgent advent of the kingdom of God and about the here and now of the rule of God in Israel. Jesus' parables must never be isolated from the one who spoke them and the situation into which they were uttered. Today, the parable of the Good Samaritan is often used as a metaphor to encourage us to engage in some virtuous or humanitarian act, and rightfully so. And we will soon see that I too want to read the parable as a motivating narrative, especially when it comes to contemporary healthcare. But in doing so, we must always remember that the story of the Samaritan was politically dangerous. It was subversive because it challenged the power of the Jewish authorities in Jerusalem and the authority of the Roman Empire. Those with power and privilege in the Samaritan story, that is, the priest and the Levite, they're not the heroes, they are the foils. It is rather the marginalized and hated Samaritan who acts in accord with the law, exemplifies the virtue of neighborly love, and cares for the injured victim. One subversive subtext of the parable is that unchallenged power and privilege can lead to complacency, indifference, and the utter disregard of those who are less powerful and in need. The legal scholar undoubtedly comes to the same conclusion once he realizes that the priest and the Levite, models of Jewish orthodoxy, are not following the law to love your neighbor as yourself. The hypocrisy of the priest and Levite who are charged with keeping the law but end up violating it breeds suspicion and cynicism. This is why we must at times pose questions to those in authority. It is also why we must continually question our own power, our own privilege, and our own way of being Christian. As Pope Francis says as he reflects on the parable, and I quote, "This simple, inspiring story of the Samaritan indicates a way of life which has its main point not ourselves, but others with difficulties whom we encounter on our journey and who challenge us. Others challenge us, and when others do not challenge us, something is not right. Something in the heart is not Christian. While it is true that the parable of the Good Samaritan is not about first century healthcare, the story does revolve around a question of healthcare justice. Who is responsible for caring for the victim left dead alongside the road? As the Catholic philosopher and social critic Ivan Illich rightly observed, the Samaritan had no ethical duty to care for the injured victim because the man, presumably a Jew, did not belong to the Samaritan people, not a part of their nation or tribe. In this context of the first century Palestine, one's ethical duty was only to one's neighbor, those who belong to the people. There was no sense of a common humanity or what we would today call a cosmopolitan ethic of universal humanity. Going to the victim meant actually challenging cultural norms, violating moral decency. As a result, the parable of the Good Samaritan invites us to ask difficult, perhaps even subversive questions about how our political decisions, social structures, cultural practices, religious authorities, and even our concept of the common good and our responses to vulnerable and underserved populations affect the way that we care for our sick neighbor. So, on June 9th, 2018, an emergency call came into the 911 dispatcher. Dispatch is here. Ambulance, what is your emergency? I need an ambulance at 67 Little Thames Place. My husband, he's 51. I think he's having a heart attack. He's gray. He's not responding. Is he breathing normally? No, he's not. Not at all. It's labored. Sounds bad. Oh my God, please help. Crying ensues. Hey ma'am, calm down. Ambulance is on its way. Please stay on the phone. Are you near him? Caller says, no, he's in the other room. My phone won't reach that far. How long will it be before the ambulance gets here? Soon. Please just stay on the line. Sorry, just please stay calm and listen to me. Indeed, that 51-year-old man is having a heart attack and he has gone into cardiac arrest. His heart has stopped beating. He is clinically dead. Every year in Canada, 35,000 people will become the victim of a sudden cardiac arrest. Only 10% will survive, and only 8% will survive without any loss of brain function. Without someone's help, without someone doing cardiopulmonary resuscitation, CPR, or using an automated external defibrillator, his heart will not restart. He will remain dead. Luckily, his wife is there to call 911. The ambulance is between 8 to 10 minutes away. The fire truck is closer. It's 6 to 8 minutes away. He has already been down without a pulse for 3 or 4 minutes. Time is of the essence. Research has shown that early and effective CPR is crucial to increasing the chance of surviving a sudden cardiac arrest. For every minute a cardiac arrest victim is without CPR, their chances of survival decrease by 10%. And by the way, after 15 to 20 minutes without CPR, it will be terminal. While emergency response times have been creeping down across Canada generally, there are still areas where response times can be quite long. For instance, in rural areas of southwestern Ontario, where I live, an ambulance might be 15 to 20 minutes away at best. And even in high-density urban centers, such as Toronto or Vancouver, actual response times can also be quite lengthy, especially when emergency responders need to reach the upper floors of high-rise condos and other large buildings. Delays created by tight security systems, slow elevators, and just the fact that it takes time to travel up 25 or more floors in an elevator can mean multiple minutes lost. To put it bluntly, a penthouse is not a place you want to be if you go into cardiac arrest. That is, unless you have neighbors nearby who can respond with CPR and ideally an AED. Surviving sudden cardiac arrest depends on a series of events beginning with someone calling 911, sometimes referred to as the chain of survival, which you can see graphically on the slides. So let me start that again. Sometimes referred to as the chain of survival. The next link in the chain, after calling CPR, after calling for help is CPR. Traditionally, this link has meant high-quality CPR performed by professionally trained emergency responders. In practical terms, though, we know that survival most often depends on a community bystander, often a family member, starting CPR as soon as possible and using an AED. And here is where I would like to pose a question to you. What can we, and by we, I mean all of us, actually do to increase the chance of survival by decreasing the time between an individual collapsing with a sudden cardiac arrest and having someone else provide CPR and using an AED? To help you answer that question, I would like to introduce you to Neighbours Saving Neighbours, a community-first response program that has been launched in Frontenac County, Ontario, which is near Kingston, and is being organized in Perth County, which is where I am in Stratford, Ontario. It is an approach that empowers lay, that is non-technically trained community members, to respond to sudden out-of-hospital cardiac arrest first, while EMS, firefighters, and other emergency responders are on their way. Neighbours Saving Neighbours begins by recruiting volunteers in the community who are willing to be trained in basic CPR. Actually, these days, the training is hands-only CPR, so no mouth-to-mouth resuscitation, just chest compressions using hands. These volunteers are also trained on how to use an AED. Typically, there are enough trained volunteers to saturate an area when a cardiac arrest call comes in. In some cases, AEDs are assigned to individuals, and in other cases, AEDs can be strategically placed in neighborhoods and properly registered. A key component of Neighbours Saving Neighbours is the use of technology, such as a mobile phone app to dispatch community members to the scene. One of the apps is actually appropriately named the Good Samaritan App, or the Good Sam App. This use of technology to dispatch community responders is important because it can even further reduce the time between collapse and life-saving resuscitation measures. In the Good Samaritan story, it was chance, fate, luck, or perhaps a miracle that the Samaritan happened to be walking down the road and he found himself in a position to respond to the victim. What the Neighbours Saving Neighbours program does is it tries to reduce our reliance on chance, luck, and even the miraculous. Instead, it equips our neighbors with the knowledge, skills, and even means to help save someone's life. The community first response approach is a simple concept, but there are significant barriers facing community first response programs like Neighbours Saving Neighbours. One barrier is cultural. We Canadians consider CPR and the use of AED too technical and too medical to be trained. There's something about it that, those of us who are not medically minded, we shy away. Part of the problem is that we've developed the idea that healthcare is a specialized field and requires specialized knowledge, skills, and language. As a result, part of the recruiting process involves reassuring the public that the training isn't onerous. This means that in recruiting and in training volunteers, the Neighbours Saving Neighbours program must use plain language and stories that speak to the community and its culture. Let me give you an example. The Canadian Heart and Stroke Foundation has been promoting the idea that a bystander can save a life by using hands-only CPR, compressing at around 100 to 120 beats per minute, while singing along to the Bee Gees' disco tune, Staying Alive. This approach uses playful pop cultural references, which not only demystifies CPR, but also subtly invites us to respond with potentially life-saving action. Second, we need to support members of our community who are hesitant to start CPR because they're afraid that they might do it wrong and might hurt someone. We have a tendency to leave the response to the professionals. To use the Samaritan story, we may see the victim, but we cross to the other side of the street. with the hope that someone more qualified will help the victim. This is especially true for family members who in that moment of crisis may be struggling with a wide range of emotions. In fact, they may not be able to assess the reality of a family member who is suffering from a cardiac arrest. Surely it must be something else. While we need to be sensitive to these very real concerns, the reality is that if the person has no pulse, they will die without CPR and someone restarting their heart, likely with an AED. Third, we also need to do a better job of allaying fears that many of us still have that performing CPR on a person may expose them to legal liability. Here we need better education on our Good Samaritan laws, which are in place that protect bystanders from legal liability. In short, and I'm not pretending to be a lawyer here to offer any sort of legal advice, in short, you are legally protected if you step in and perform CPR. So do it. And fourth, perhaps the most complex challenge is to identify larger motivating narratives that help community members frame their role in responding positively to victims of sudden cardiac arrest. Because these motivating narratives often belong to larger cultural, national, or religious stories, they can help members of the community ascribe meaning to their actions and overcome any fear, lack of confidence, or hesitation members may have in responding to someone in need of life-saving help. Here is where the story of the Samaritan can play a vital role. Indeed, the parable of the Good Samaritan is an apt motivating narrative because it actually speaks to the hopes and challenges we face in Community First programs. On the one hand, the parable is the story about a lay bystander, the Samaritan, who goes out of his way, apparently not crossing the road, but certainly crossing cultural and religious convention to come to the aid of a half-dead victim. Without the Samaritan's helping hand, the victim would have presumably died. In this respect, the parable is about doing the right and virtuous thing, recognizing the dignity of the victim, responding with mercy and compassion, and acting on the moral imperative to love your neighbor. Let me return to our 9/11 call. That caller was actually my wife, and I was the victim of a sudden cardiac arrest, which was brought on by a heart attack. The culprit, and that's the language they use, the culprit being a 99% blockage in the right coronary artery. Just a few minutes prior to her calling 911, I had told my wife, I don't feel well. She was about to leave for the afternoon. I was going to be home with my 2 young boys, who were 6 and 4 at the time. Before leaving, she peeked into the living room where I'd sat down. I was slumped over and not responding. She leapt into action. She tried to hail our next-door neighbors, who are physicians. They weren't home. However, a construction worker we know, who just happened to be at their house finishing job, he heard my wife say, "Scott's having a heart attack." He rushed in the house to help. Another neighbor heard the commotion, and he came to see what he could do. My wife called 911 at that point. As one of the neighbors was coming into the house, he saw the physician neighbor driving up the street. He flagged her down and told her I was in trouble. She rushed in, checked for a pulse. There was none. My neighbors got me down on the ground, and within 4 or 5 minutes of my collapse, she began hands-only chest compressions. She continued for the next 15 minutes. As the fire department showed up with an AED and then the ambulance. I was shocked 3 times by the AED to no avail. Declaring a scoop and run, they loaded me into the ambulance, now with a mechanical chest compression device known as a Lucas, strapped to my chest. On the way to the hospital, my heart started to beat again. My neighbors saved my life. Having been a victim whose life was saved by my neighbors, the story of the Samaritan has taken on new meaning for me. In particular, I've come to realize that our focus on the scandalous act of neighborly compassion in the parable has perhaps prevented us from considering more fully how the crisis affected the actors in the story. This, of course, is asking far more from the parable than it can ever deliver. But still, in the parable itself, the fact that the Samaritan gives money to the innkeeper and promises to give him more if needed is a clear indication that the Samaritan's care for the victim entailed an ongoing relationship, a new way of being with the victim neighbor, and thus an ongoing ethical commitment to the other. I would like to focus on the innkeeper. In the Christian tradition, we've honored the actions of the Good Samaritan by naming hospitals, rehabilitation centers, and hospice care facilities after the Good Samaritan. But in doing so, perhaps we've missed an opportunity to honor the innkeeper as well. For it is the innkeeper who cares for the victim in the longer term. It is the innkeeper who will journey with the victim as he goes through his difficult recovery. By focusing our attention on the innkeeper, we realize that today's innkeepers are the doctors, nurses, and other healthcare workers who have given their lives to care for others. For many of them, they talk about their work in terms that sound much like a religious calling or a vocation, even if they're not religious. They are a little bit like Dr. Ryu from the plague. There are sick people, and they need care. And those of us who've been around the church, have too often witnessed, it can be easy to take advantage of people who give themselves to others out of a larger sense of calling. The Samaritan's commitment to pay the innkeeper is a good reminder that healthcare workers must be justly compensated, that they must also have safe working conditions and leisure time to be with families, friends, and loved ones. Perhaps most importantly, neighbors within the community, that is all of us, must ensure that our INS, I-N-N-S, our healthcare institutions and social service providers are adequately funded to meet the needs of those who are sick. While underfunding public health adversely affects all of us, it is most acutely felt by the marginalized in our communities, the poor, people experiencing homelessness, and our indigenous populations, just as an example. As Catholics, we understand the public funding of healthcare as part of our commitment to the common good. It is a matter of social justice. Drawing once again on the Samaritan story, Pope Francis puts it this way, and again I quote, "There are times when we feel like the victim, badly hurt and left on the side of the road. We can also feel helpless because our institutions are neglected and lack resources, or simply serve the interests of a few." End quote. Our primary goal should not be to stumble by chance upon a victim who is chronically underserved by our institutions, but rather to ensure that our institutions are equipped to serve all who are unwell and in our communities. I also want to return to the Samaritan, the bystander, who chose to care for the wounded man along the road. If we read the story too quickly, we might easily assume that the Samaritan went away largely unaffected by the events of that fateful day. But we know this is likely not the case, because But we know this is likely not the case because he has already implied to the innkeeper that he has chosen to establish a new relationship with his neighbor. What's missing in this parable, and frankly, what's often missing in stories of bystanders heroically coming to the aid of a victim, is how the Samaritan's actions in saving the man's life affected him emotionally and spiritually. I ask these questions because we know from stories shared with the Bystander Support Network, which is here in Canada, that bystanders often have difficulty making sense of their experiences. Indeed, research tells us that bystanders can experience trauma, in some cases leading to diagnoses of post-traumatic stress disorder. Those of us who work with bystanders often call them the forgotten patients. On a personal note, this is certainly the reality for the neighbor bystanders who saved my life. As the victim patient, I encountered world-class medical professionals and extraordinarily high institutional standards. My physical healing has been stellar. I suffered no emotional or spiritual trauma, in part because I don't remember anything from that day. But the story of my heart stopping also includes my wife, Megan, my 2 young boys, my next door neighbors, and those who love and care for me. In other words, my community. Regrettably, my 2 boys saw a lot. Again, they're 4 and 6 when this happened. They saw their dad lifeless on their living room floor, then being put in an ambulance with a machine pounding away on my chest. You don't unsee those things. They're always there. My wife, Megan, experienced so much. Her world was completely shaken. Even my doctor neighbors, people who are trained, experienced emotional trauma because of their actions saving my life. It is now almost 4 years since the thing, as my boys called it, and our family continues to struggle. I have survived a cardiac arrest, so too did my family. I survived my heart stopping for 20 minutes, so did my family. My formal supports I needed to survive and flourish have been numerous and incredibly helpful. I cannot, however, say the same for my family survivors. We are on a journey together, but they need more support. In short, being a bystander, being a good neighbor, can come at a cost. But in community, we recognize that we may at times need our neighbor to come to us in a time of need. Pope Francis puts it this way, and I quote, "Each day we have to decide whether to be good Samaritans or indifferent bystanders. And if we extend our gaze to the history of our own lives and that of the entire world, all of us are, or have been, like each of the characters in the parable. All of us have in ourselves something of the wounded man," which I didn't get a chance to talk too much about, "something of the robber, something of the passers-by, and something of the Good Samaritan. My hope is that we choose the way of the Samaritan." Thank you.
Thank you, Scott. We do have time for questions. If there are any questions either from those present or online, please feel free to ask them. Just going to check the online questions. Scott, I have a question I'd like to begin with. I appreciated the focus on the subversive nature of Jesus' parable, but I've also wondered, and it was something you were getting at when you talked about some of the barriers to neighbors sort of stepping in. I've wondered if the priest and the Levite might be fearful of the robber, fearful of robbers, perhaps plural. And is that a regular barrier that you see ongoing, and not just with perhaps heart attacks, but with getting involved at all, that not just with Good Samaritan laws, or they might be legally responsible, but they're just scared to help because they wonder if they're capable. Does fear enter into it?
Yeah, fear is a big part of it for sure. There's 2 things. Fear, certainly in the parable, is I think you touched on that, with possibly the robbers coming back. There's no doubt. I think most interpreters, and you can correct me if I'm wrong here, John, most interpreters will say that that the reason why the priest and the Levite did not care for the victim is that they wanted to avoid a kind of ritual uncleanliness, because the man was half dead, naked, perhaps dead, that had the priest and Levite gone to the individual, that would have somehow made them unclean. So fear, yes, but I think also there is a kind of cultural, religious reluctance too, that served as a barrier to keep them away from going to the victim. Yeah, the Samaritan, as I talk a little bit about here, the Samaritan would also be, and this is referring back a little bit to even Illich, the Samaritan is actually putting himself in danger. He's crossed a border. He's likely living in the province or the sort of client state of Samaria. He's crossing a border into Judea, which is the sort of state where the Jews are living. So he's in a territory that is not his home. So he's on very unstable ground geographically. And it's really important in the parable that that is the case, because it is one of the very few parables that has a geographic location in it. It's the road from Jerusalem down to Jericho. So the geography matters. And that would have been, it wouldn't have been necessarily automatically dangerous for the Samaritan, as long as the Samaritan keeps within his lane. He does not keep within his lane. He goes off script. He goes to this Jewish victim and then engages in something that would have been scandalous, right? So there is something there. You have to overcome the cultural and arguably religious barriers. You have to overcome the fear. And in some respects, even on something that is relatively politically benign as, sudden, responding to a sudden cardiac arrest, it's still there. Structurally, it's still there. I mean, in my talk tonight, I focused on that. We could talk about a whole slew of other, arguably more politically, what's that right word here, explosive topics. Things like safe injection sites, dealing with people who have substance abuse disorders. How do we respond to them? What barriers and fears do we need to overcome to respond to them where they are? That can be very difficult.
Yeah, thank you. We do have some more questions. Sonia, first of all, says that was so inspirational. Thank you. And is there also a fear of not being able to help and always living with the trauma that someone might have made things worse?
Yeah. So I think I hear two things in that. So I do know of people who had an opportunity to step in and to go to somebody's aid and chose not to. And they've had to live with this. I've heard through some of the bystander network and others. So in some cases, the victim survives. In some cases, the victim perishes. There is almost always a kind of what if that they engage in that is psychologically difficult. In some cases, it's debilitating. In some cases, it's transformative. I know a number of people who, when they didn't go upon reflection, immediately went out and started attending CPR classes, became advocates for community responder programs. Because of their failure to act, they didn't want that to be the norm. They wanted to challenge that norm and press it into the community and say, no, we do need to act. And this is not just for victims of cardiac arrest. This, again, could be people who are street involved, people who victims of sexual violence and so on and so forth. So it's what can we do to step in, to change the culture to ensure that that happens. So there's that. I'll stop there. Hopefully that answered the question.
So another question has come in. This is a very practical one. You spoke of the program, this is from Alexander. You spoke of the program in Ontario to train people to intervene and distribute equipment. Do you know if there's a BC equivalent in your branch?
I do. Remarkably, though, they're very few and far between in our generally populous communities. Where we are seeing most of them spring up organically is within our Indigenous communities. And the reason why they are in our Indigenous communities is that oftentimes, and I go back to my comments in my talk tonight, is that they are actually underserved medically. There are oftentimes no ambulances, there's no EMS personnel. It is largely the community who are responding. In some cases, they will need to load up the victim, stick them on a ferry, get them to a landing pad where a helicopter can gain access. So it's almost by necessity that these types of community first responder programs have been put in place. I will say this, maybe not so much about BC, but generally. And again, this seems like a fairly politically benign topic. There are social justice elements around it. There's a potentially politically subversive message here. But let me focus on something. To get these kinds of programs in place, you have to overcome so many political and bureaucratic barriers for them to become effective. Because what you're essentially doing is that you are inserting a bystander formally into a process that is highly medicalized. That's one part of it. So you have to get all of the levels of bureaucracy on side in order for these kind of things to happen. So you have to work with fire, you have to work with emergency services, you have to work with public health, and so on and so forth. It's a lot of work on a bureaucratic side of things. The other thing that's difficult, and you wouldn't think that it would be, is that it is hard for politicians, for whatever reason, to get behind programs that ensure large populations being trained in CPR. In very few provinces in Canada, there are no required, there's no requirements to have CPR. I mean, in some provinces now, it becomes a part of the curriculum in grade 7, grade 8. In other parts of the world, in some parts of Canada, being trained in CPR is actually a requirement to get your driver's license. Why would you not tie something that is a life-saving measure to something that is so much a part of who we are as Canadians, as people in the global north? Frankly, I'll be honest with you, and this is where I might get myself in trouble with some of our experts, the training is not onerous at all. So a lot of these neighbor saving neighbor programs that we're piloting in Ontario, the training will only be perhaps 30 minutes at most, because it is so basic. It is literally, and I don't know if people can see me, taking perhaps your weaker hand, putting it on the person, placing your stronger hand on top, interlocking your hands, and then doing chest compressions basically as hard as you can at a rate of 100 to 120 beats per minute. That will keep the circulation going long enough to save a brain and perhaps save a life. It's that simple, right? That's the kind of thing we can do, and it doesn't even necessarily need to, these things don't even necessarily need to be in person. They can be done remotely on the computer. Now, I am a part of a study that is going to be published with some colleagues that are part of some of the network that you talked about, John, in my bio. It's interesting that in a recent survey, people want to be trained in CPR. They don't actually want to be trained remotely. They actually want an embodied experience of doing it. And the theory here is that they actually want the feeling of doing it, which I think is important. I don't know if it's essential, but it is important. The key thing is whatever we can do to motivate people to respond to this particular emergency, and we have the capacity to do it. So, yeah.
You do have another question. Someone writes, I learned in a history and philosophy of medicine class that much of medicine hangs on accompanying the person who is ill. Has medicine become an institution that does not recognize this any longer, and which has resulted in limiting the layperson's response?
Oh, for heaven's sakes. This person must be reading a chapter in my book. Yeah, for sure. I mean, so where I would go with this particular question is, or whoever it is, uses the term accompaniment. It's certainly a part of our medical and social services vernacular. It is also, and I think this is important for us Catholics to know, it is also very much a part of liberation theology. So the theology of accompaniment is that you journey with people who are marginalized and poor. You help them where they are in need. What can they do to get out of whatever challenge that they're in? It was picked up in North America by a man by the name of Paul Farmer. I don't know if any of you have heard of Paul Farmer. He was a professor of global health at Harvard University and was very much influenced by liberation theology in Latin America. Paul just died recently, unfortunately. But he has developed a theology of liberation which has a kind of secular veneer to it because he's trying to reach broader populations. But foundationally for him, it is rooted in the base community of Latin American liberation theology. And I think this is key. It goes back to some degree the Good Samaritan. The story of the Good Samaritan isn't solely about action. It is. I mean, there's action there. You're going to save somebody. But what that action is about, it's about the reformation of a community. It is precipitating a new way of being, right? Being Christian, being providers of healthcare. And I think that is fundamentally key. So I can go on with this topic forever and ever. But let me say this. I think a lot of our healthcare, and I'm completely overgeneralizing, and some of my colleagues will be forever upset with me for saying this. But I would say that, anecdotally, a lot of healthcare these days is transactional. It's consumer driven. The patient is the consumer. The patient is the one who, particularly in the United States, largely dictates the services that they receive. If you want a genetic test, it will be the patient, the consumer, who will order that genetic test. Why? Because they are willing to pay for it. Okay? We don't quite yet have that system in Canada. I hope we don't go there. We still have a bit of a different understanding, sociological, when it comes to a kind of collective nature, a kind of common good in our healthcare system. If, however, we go the way of privatized healthcare, I can assure you, healthcare will become far more transactional, far more consumer driven, and we will be far less interested in accompaniment, in understanding healthcare as a new way of being as a collective, and we can almost start thinking, okay, how does this affect us as Catholic healthcare providers? What does it mean for us? Because that's not how we think. It's going to put severe pressure on us.
We have one more here. Do you want to go ahead, Rob, and ask your question? Please do.
Thanks very much for the talk. Picking up on that Paul Farmer reference you made, we're still in a pandemic. We've just gone through a couple of years of it. Do you think there's reasonable hope that this shared experience might awaken a little bit more of the Samaritan in us? The fact that we found out that we were vulnerable and we can't, by wealth or whatever, protect ourselves as much as we thought we could, that this is a shared experience and it might evoke some new level of empathy at a wider level? Do you think there's any hope for that?
Yeah, thanks for that question, Father Rob. Maybe it's just because I'm in a bad mood or something. But I want to say yes. I want to say a hopeful yes. But I can't help looking at reality. I mean, in my mind, we are at a pivotal time. You saw in the slides that I had, I referenced Hannah Arendt and her book, Men in Dark Times, which she wrote. It was a series of essays that had been published over time. And she was trying to find ways to look for hope in dark times. I think there is hope. And I think, frankly, the Samaritan story is hope. And if we focus on that story, then we can understand that there is a good and there's value in some of our shared experiences of supporting neighbors who are sick, neighbors who have lost loved ones. Again, a lot of my story tonight has been personal, but my neighbor back in Stratford, he died of COVID just 6 weeks ago. You know, and I don't really want to focus on this, but he refused to get vaccinated, and he didn't have to die. And this goes to the sort of the darker narrative, I think, that's floating around out there, Father Rob, is that there's a competition that's taking place. There's a real push to say, okay, if we want to do things for the common good, where we engage in public health measures to protect the most vulnerable in society by wearing masks, by putting regulations in place, so that you have to be at a certain distance and so on and so forth. Okay, these are done for the purposes, arguably, of protecting those who are most vulnerable. But then you have the flip side saying, it is my right to not wear a mask. You are violating my freedom. We have people who are actually at risk. Truck drivers, meat packers, traveling across Canada and into Washington, D.C., saying you are violating my freedoms, and calling people, politicians who try to enact policies arguably to protect the vulnerable, saying that you are equivalent to some of the most despotic fascist rulers in the history of humankind. We've got competing narratives. And so this is why when we think about narratives, the stories that we tell, they are so fundamentally important. So for me, the Good Samaritan is one of those fantastic stories. It is a story that comes from a parable that Jesus gave in the first century. It was politically subversive. Okay? Fantastic. It is also a story that is full of hope. It is a story that we need to continue to repeat. It is not essentially a Christian story. It is essentially a human story, caring for the victim because it is a right and virtuous thing to do. That's the story we need to tell.
This next question, Scott, aligns very much with this answer. Dr. Kline, I'm interested in the story part of your presentation. In a world overflowing with information, how to make people know these stories? How not to be dehumanized when there's so much suffering in our societies? Perhaps two parts to that question, that I think the stories maybe can help humanize us with respect to our neighbor.
Yeah, oh my gosh, we are in some respects, kind of going back to my previous, we're in this weird, ironic situation where I'm advocating for stories. I enjoy narrative ethics. Alistair, oh my gosh, I lost his name. The philosopher, help me out here. McIntyre, thank you, Alistair McIntyre. He was once asked, thank you, Father Rob, and everybody. McIntyre once was asked, tell me about your community, right? And his response was something, well, what you're wanting is my stories, right? So he was saying, well, what does my community look like? Well, go read my stories, go hear my stories, talk to people. Today we are, in some sense, overrun with stories through social media and so on and so forth. I don't think that there is one story. I think there needs to be a way of engaging in conversations that are in some sense humanized. And here I'm going to get almost becoming a Luddite. I think some of the challenges that we have right now, partly because of COVID and some of the social isolation, is that a lot of our stories right now are being shared in isolation. And they are being shared in an echo chamber. For those of you on social media, the social media that you get is controlled by an algorithm. You are fed stories that you agree with. Your stories are not being challenged, right? You're talking essentially to yourself. Your stories are being affirmed. What we need, I would suggest, is not Elon Musk or any of these folks trying to send us the messages that we want for commercial reasons. What we need are embodied conversations where people can get together and have authentic discussions about issues that matter. This needs to, frankly, it needs to start in our churches, in our synagogues, where there is disagreement within those bodies. But what we continually are doing right now, and it is not healthy, is that we retreat into our tribes and into our silos. We suffer from the same plague that the Samaritan faced as he was walking on the road from Jericho to Jerusalem. Right? We need to share. We need those other people's stories. We need to overcome some of those boundaries. Hopefully, going to Father Rob's questions, that post-pandemic we can start doing this with the realization that that is a healthy way to move forward. It's not going to be an easy way to move forward, but it is certainly a much healthier way than the kind of tribalism and messages and stories that we are force-fed in our social media inboxes. It's a bit sermonic, sorry.
We do have another question. Dr. Kline, I really like how you put it. The Samaritan story is not just a Christian story. I hope I heard that right. Rather, it's a human story. So I think if there is a question there, I think it is, did she hear you correctly? That you're talking about this is not simply a Christian story, but a human story?
Yeah, it is. It's a story that, regardless of your religious affiliation, whether you have no religious affiliation, it's a story that rings true with people. It's a story that is almost a kind of, I don't want to get too sort of biblical and hermeneutical here, but it's kind of an story. It's a foundational story. It is emblematic of a lot of stories with ethical import in them. You have tension, you have rising tension, and then you have an ethical problem that needs to be solved. The Samaritan going to the victim goes off script. The people who were hearing this in the first century would have seen this as scandalous. They would have been compelled to talk about it. The purpose of Jesus' parables, on the whole, was to get people within the community to talk about it. They were not to be done in isolation. They were not to be considered in isolation. Going back to some of the comments that Father Gerhard Lofink says, they are not general ethical admonitions. They are problems. They are conversation starters that were brought back to the community. And it's like, how do we figure this out? What does this mean? How does it affect our life, not just my life? There's a collectivization in those parables. That, I think, goes beyond just simple tribalism. That's the story of the Samaritan. Our neighborhood has been expanded.
Are there any final questions, either from folks at home or here present, before we begin to wrap it up? That's almost a perfect summation of the Samaritan we got right there. A number of people have thanked you, including Bob, for the component that you brought to bear of both the physical healing and the spiritual healing. I think that's really significant. Any final questions?
Great. Thank you, John.
Thank you so much.
Yes, thank you.
Let's offer a round of applause, and at home as well. I mean, there is so much here about systems, about caring for each other, about neighbors. I mean, so much to chew on. And I think the number of questions and the quality of the questions really spoke to that. This is a generative talk. I don't think we're going to just stop with this. I think it's going to keep us thinking and keep us reflecting on this. So I thank you very much, Scott. And one more time, thank you. For those who are here, there are some refreshments. Now, there is one plate of food with nuts, so just to be aware of that. And other than that, I think it is safe. So please join us over in Plato's Cave if you have time, because we don't want to take them all home. We'd like to eat some tonight together. All right. Thank you so much. Thanks, Scott.